Good evening, everyone. We welcome you all to Ortho TV online POSI webinars, and we hand over the proceedings to the POSI team.
Good evening, friends. Welcome to the POSI webinar. Today we have a very interesting webinar on the malunion of upper extremity fractures. The coordinator and the moderator for this session is Dr. Rujuta Mehta. So I request her to take over the session. Please, Rujuta.
Sure. Thank you so much, Dhiren bhai. Good evening, everyone. We are very, very fortunate to have a very astute speaker with us today. He is none other than Dr. Joshua Abzug. From 2015 to now, he is the Deputy Surgeon-in-Chief and the Chief of Pediatric Orthopedics for the University of Maryland Children's Hospital, Baltimore. He's also the director of the University of Maryland Brachial Plexus Clinic in Baltimore. Thomas Jefferson University Medical College at the Philadelphia Hand Center and Shriners Hospital, and at St. Christopher's Hospital for Children in Philadelphia again. Every medical education of his has been in Philadelphia. He's also featured amongst the top doctors and amongst the who's who of America many, many times. He's a fellow and member of the AAOS, POSNA, and traumatology societies, amongst many other societies. His leadership positions include being in the education chair and the academic chair on several associations, seminars, international symposia. And he has an exhaustive CD of 74 pages. I'm sure I'm not going to be able to do justice to all of those things here. But to quickly summarize, he has about 124 articles in peer-reviewed journals, 4 books, 54 book chapters, 251 speeches so far. And his interests include fractures of the upper extremity, skin lesions, neuropathies, brachial plexus, congenital and problems. He's had several publications and book reviews to his name, and also is a member of the Adrian Flat Society and Microsurgery Society. He's got a whole lot of interesting work on wrist anatomy besides the interests that I've named so far. And he's a good philanthropist. He runs a camp for children, a free camp for children in Egypt, and a support group for any child with a limb length difference. And he also has a very interesting hobby, which we came to know very recently, of collecting firefighting helmets from across the globe. Ladies and gentlemen, I give you Dr. Joshua Abzug. I welcome him on behalf of POSI and request him to start today's talk.
Well, thank you, Dr. Mehta, and thank you, everyone, for having me today and this evening. I hope everyone is staying healthy during these crazy times that we're experiencing all over the world. My charge tonight is to discuss the malunions of the pediatric upper extremity, and I will focus on various fractures throughout the upper extremity and discuss potential ways to prevent malunion and how to treat them as we go on. Obviously, we will have a quick Q&A session tonight after my talk, but please feel free if you have questions to email me, as you see my email listed there. So, I think in my experience, malunions involving the upper extremity are actually fairly common, unfortunately. And sometimes we allow the malunions to occur in an intentional manner because we expect the child to remodel the fracture, and therefore there's no need to get an accurate anatomic alignment. The malunions can be defined as a nascent malunion, which is early on, and there's callus formation present, but the malunion is not fully established yet. Or it can be a definitive malunion where the fracture is completely healed, and that would require more formal osteotomy. And these are quite different approaches to dealing with these types of injuries, whether it's a nascent malunion or a definitive malunion. It's always important for us to recognize when we discuss and consider treatment of a malunion, whether or not the malunion is functionally limiting or it's cosmetically appealing, or both. And that will help guide us in our treatment and what our goals of our treatment are. So I think our jobs, particularly those of us that take care of children, is really to determine whether or not the fracture will remodel or if intervention is even needed. And this really becomes the art of medicine and truly the art of pediatric orthopedics in knowing what is acceptable and what is not acceptable. Because certainly if the fracture will remodel into acceptable alignment and permit adequate function, then we do not need to intervene as the surgeon. So with that background, we're going to work our way from proximal to distal through various different fractures. I'll begin with proximal humerus fractures. These account for approximately 5% of all childhood fractures, and because 80% of the longitudinal growth of the humerus comes from the proximal physis, these have a tremendous remodeling potential. Furthermore, we have an extremely big arc of motion, as you see depicted in these pictures, about our shoulder, and therefore we can accept some deformity present in that region. Because of this, the vast majorities are treated non-operatively, even if a small malunion will develop. And here are some examples I've pulled out regarding the tremendous remodeling potential, especially due to that 80% of growth that's present. And this you can see from this Yellow Journal article back in 2015 with an excellent positioning of the proximal humerus in that young child. And here's just another example of tremendous remodeling occurring in these young children. So when should we think about intervening? Well, certainly if an impingement is occurring, if there's substantial decreased range of motion, and in those children that truly have increased physical demands, such as sports participation, where the decreased motion will inhibit their function. And what I've learned is that these fractures that go into varus really can get abutment and impingement of the proximal spike of the distal fragment up against the acromion, and that will limit motion. And these are some criteria that we can see as acceptable for depending on the age of the child. We can see as the child gets older in age, closer to skeletal maturity, we can accept less angulation and less displacement. So if we're going to correct the malunion due to impingement or functional limitation, this is the operating room setup I like. Utilize beach chair positioning with the fluoroscopy unit coming from the opposite side of the bed, as you see depicted here. I perform a standard deltopectoral approach, and I heavily utilize the cob or bone hook to aid in getting the reduction by really pulling on that distal fragment inferiorly, as it tends to want to ride up due to the pull of the deltoid. In early on nascent malunions, there may be entrapped structures that prevent an easy reduction, and this can include the periosteum, the long head of the biceps tendon or the capsule, all of which need to be removed from the fracture site or malunion site. The fixation in the vast majority of children that still have an open physis, in my hands, is Steinman pins, as you see depicted here. In older children where the physis is already closed or basically closed, I think plate and screw fixation can be utilized. There are certainly other options, but these are my preferences. So here's a case example of a 15-year-old right-hand dominant wrestler. We can see that this is a nascent malunion with some early callus forming at the level of the fracture site. And if we look at what's happening, you can see that the distal fragment is really getting pulled proximally and laterally, really primarily due to the pull of the deltoid on that fragment. And this is going to lead to impingement that will inhibit this wrestler from performing in his desired sport. So here are his intraoperative fluoro images, and you can see the impingement that will occur right up against the head of the humerus and the acromion that will limit the motion present. And we thought we could break up the callus with some osteoclasis and tried to just perform a closed reduction and percutaneous pinning. And I think we would all agree that these radiographs look acceptable in alignment with good positioning of the pins. However, you need to be very careful because of the motion present about the proximal humerus that this is not really what's happening. So in my hands, I think live fluoroscopy is necessary to ensure appropriate fixation is present when performing pinnings in a closed manner of proximal humerus fractures, because certainly I think we would all agree this is worse than where we started. Ultimately, this was performed with open reduction and fixation, as you see depicted here, to improve the alignment and prevent the impingement from occurring. And we can ensure that we do not have that malunion that would have occurred with the closed technique. Here you can see, that the impingement is resolved with excellent abduction being able to be performed. Here's another case. You can see again the early healing with callus formation present, substantial 100% displacement on this scapular Y view, and this football player who's 13 years of age. Again, we would expect substantial impingement present between this proximal spike of the distal fragment up against the acromion with attempts at abduction. And here you can see the malunion further. This was approached in a similar manner as we discussed. And here you could see again, really that impingement that will occur. This was performed with a deltoid pectoral approach with an osteotomy present to break up that healing directly into that malunion site, and then fixed again with the Steinman pins in acceptable alignments. And here it is 3 months postoperatively, and ultimately the patient was able to return to their sport. So we'll move distally now to the elbow region and discuss supracondylar fractures. Number one malunion that occurs following supracondylar fractures is a cubitus varus deformity. This can occur with casting alone or even following pinning procedures. And really, this is primarily due to inadequate fracture reduction. Most commonly, this is just a painless deformity, and these children have good elbow motion maintained. However, bad things can happen. One, obviously, it's a cosmetic problem. Two, you can have repeat fractures, particularly of the lateral condyle, as was described by Takahara and colleagues. And three, you can have snapping medial triceps tendon that can occur due to the deformity present about the elbow. The most worrisome complication is really tardy posterior lateral elbow instability. And this does not present until 2 to 3 decades later, where you have instability present at the elbow due to this cubitus varus deformity that's present. The child will develop elbow pain or young adult and recurrent instability. And this was really noted and popularized by Sean O'Driscoll at a Mayo Clinic about a couple of decades ago. And what's happening is really that the cubitus varus is altering the mechanical alignment of the elbow. So you have medial displacement of the mechanical axis with an altered vector of the triceps pull. And this repetitive external rotation torque that's applied to the ulna will eventually lead to attenuation of the lateral collateral ligament, and ultimately the patient will develop posterior lateral rotatory instability, as I showed in that video there. That is certainly a reason for correction in an adult, and certainly a discussion should be had with patients and their parents when cubitus varus deformity is present to see if it's just a cosmetic deformity, and you should discuss these potential risks that I just discussed. When treating all malunions, I think that simple is better. And in this case, for a cubitus varus deformity, a lateral closing wedge osteotomy is the simplest procedure to perform. When there's an addition of coronal plane deformity in addition to the sagittal plane deformity, then a biplanar closing wedge osteotomy, in my hands, is the simplest operation to perform and is my preference. Here's a case example that underwent a biplanar osteotomy to improve both the sagittal plane deformity as well as the coronal plane deformity and reinstitute some flexion into the distal fragments. And here it is in follow-up. Certainly a dome osteotomy is an option as well as a step cut osteotomy. However, these treatments are much more involved and much more technically demanding. And these are really reserved for those cases where simpler procedures cannot be performed, such as I just showed. When performing the cubitus varus closing wedge osteotomy, I think this technique is technically straightforward. The union is reliable. The lateral prominence that occurs is typically asymptomatic and unrecognized and has a very low complication rate. The procedure is performed utilizing a lateral approach along the supracondylar ridge. The brachialis is elevated anteriorly and the triceps elevated posteriorly. Malleable retractors can be placed across the humerus as depicted here. Subsequently, K-wires can be utilized, which will determine the extent of the lateral wedge. The first K-wire is placed parallel to the distal humeral joint, just above the olecranon fossa, and the second K-wire is placed perpendicular to the humeral shaft. This, by default, will determine the amount of the wedge that should be removed to correct the deformity. When performing the osteotomy, it's important to leave the medial cortex intact and then remove your bone wedge. that you created. 2 K-wires can be placed provisionally, just like pinning a supracondylar fracture from the lateral aspect of the elbow. And then you can crack that medial cortex by applying a valgus moment and just advancing your 2 K-wires from the capitellar region across your osteotomy site. In young children with open physes, those K-wires can be left as a definitive fixation. In older children or young adults, one can perform a medial incision to identify and protect and transpose the ulnar nerve, and can translate that distal fragment medially to reduce that lateral prominence. This can then be fixed with plate and screw fixation. The following is a video describing a technique that I made with Scott Cozen, one of my mentors, that will walk you through this exact technique.
This video will demonstrate humeral osteotomy for cubitus valgus using staples for internal fixation. The child is a 12-year-old Guatemalan treated for a right supracondylar fracture by cast immobilization and developed cubitus varus. Note the varus on the right compared to the valgus on the left. X-rays confirm cubitus varus malunion. A lateral incision is performed along the supracondylar ridge. Tourniquet control is used for hemostasis. Deeper dissection is performed to identify the supracondylar ridge that is elevated via subperiosteal dissection. One must clearly expose the distal humerus in preparation for osteotomy. K-wires are introduced at the intended wedge to be removed that was planned prior to surgery. The wedge is off axis to decrease the lateral prominence. Here the wedge is designed, and an oscillating saw is used to remove the wedge under copious irrigation to limit thermal necrosis. The wedge is removed, leaving the medial cortex intact. Here, the wedge can be seen removed from the wound. Large Kirschner wires, Steinmann pins, are introduced from the lateral condyle in preparation for provisional fixation. Here, the medial cortex is cracked, and the Steinmann pins are driven across the osteotomy for provisional fixation. In this instance, staples are used for definitive fixation. A series of steps are used to insert the staples, one lateral and one anterior. Here, the lateral staple is impacted. Next, the anterior staple is placed in a similar fashion, with the jake preparing for the tines of the staple, and then the staple is inserted. A close-up view shows the osteotomy reduced and adequate staple fixation for rigid internal fixation. Range of motion and clinical examination shows correction of the valgus, full flexion, and full extension. Standard closure is performed, followed by cast immobilization for 4 weeks duration.
So that obviously utilized staples as opposed to the Steinmann pins or plate and screw fixation. Obviously, there are lots of different ways to stabilize the osteotomy, but the technique itself is all the same. We'll move distally to forearm fractures. So I think we all understand that the forearm is a paired bone mobile structure with both the radius and ulna really being intertwined due to the interosseous membrane and acting like one. This really performs the stability of the forearm with the aid of the interosseous membrane and allows for rotation of the forearm. The vast majority of forearm fractures in children can be treated with closed reduction and casting. In the US, quite often conscious sedation is utilized to obtain an adequate reduction. And again, this goes back to understanding our acceptable limits and what will remodel and what will not remodel. Things that are more difficult and can lead to problems include proximal radius fractures, fractures that lead to decrease in the interosseous space, and patients that are skeletally mature or approaching skeletal maturity. Some propose these rule of tens, which mean that a child less than 10 years of old can accept up to about 20 degrees of angulation, but a child greater than 10 years of age can accept up to about 10 degrees of angulation. Malrotation is not well tolerated. There are people that suggest that only up to 30 degrees of malrotation is acceptable in nature. If you have bayonet apposition of both the radius and ulna in acceptable coronal and sagittal plane, then one can consider leaving fracture in a 100% displaced and shortened manner, as long as the child has 2 years of growth remaining. Malunions of the forearm lead to lots of functional problems, particularly due to loss of rotation. Certainly, there can be associated cosmesis as well. Here's an example where you see this child with the right forearm fracture, again, a proximal radius malunion that led to decreased forearm rotation, particularly with regard to supination, but also with regard to pronation. Malunion correction that occurs less than 6 weeks from the injury can be done in multiple manners. Sometimes it's as simple as just wedging the cast to prevent that nascent malunion from occurring, or even if there's a little bit of callus formation present. Certainly, early on, we can remanipulate the fracture and line it up into acceptable position. And then certainly we have more advanced techniques to correct the deformity and fix it. This can include an osteoclasis, where again, we break up the callus formation percutaneously, utilizing typically a Steinmann pin or K-wire. And sometimes if there's enough bone healing, open osteotomy is needed. Osteoclasis should be definitely in your armamentarium as we discuss fractures of the forearm, wrist, and hand. One can consider a mini open reduction of the radius if the osteoclasis is unsuccessful, and placement of the IM nail without need to formally open up both fractures. This case had a mini open reduction with IM nail fixation of the radius, but a closed osteoclasis of the ulna, minimizing the scarring and invasiveness of the procedure. These have been shown to do quite well in children, and you can perform formal osteotomy when necessary, particularly if there is malrotation present. I think it's important that we understand the normal anatomy, with the radial tuberosity and radial styloid roughly being about 180 degrees or opposite each other, as you see depicted here, the radial tuberosity on the top and the radial styloid on the bottom, and that should pretty much always be the case. When performing osteotomies of the forearm, again, I think keeping it simpler is easier, and closing wedge osteotomies are what is ideally performed. In this case, where one would perform a closing wedge osteotomy of the radius, you would need to do a simultaneous osteotomy of the ulna, not to correct deformity necessarily in the ulna, but certainly to shorten it, as performing the closing wedge osteotomy of your radius by default will shorten your forearm, and if you do not shorten the ulna, you can lead to ulnar impaction syndrome becoming present. It's important to recognize if you perform an opening wedge osteotomy, this can stretch the neurovascular structures and increase the chance of compartment syndrome, and that should be avoided. The approaches are very straightforward. One can perform a standard volar approach to the radius and a direct approach to the ulna. In children, if possible, I think it's better and more optimal by smaller plates, as really we can place these children in casts different from our adult colleagues and allow for prolonged periods of immobilization as long as the fractures are in good alignment. We would not necessarily need to have early range of motion and utilize big screw constructs. At times, I will only even utilize 4 cortices on each side of my osteotomy, particularly in younger children, to minimize the amount of hardware and invasiveness of the procedure. Occasionally, we have substantially malrotated and angulated fracture malunions. And this has been popularized over the last decade throughout the world, the utilization of computer-assisted corrective osteotomies. Here you can send a CAT scan of the malunion to a company that can fabricate these jigs, and these jigs can be utilized to make multiple osteotomies to correct the deformity, and then placement of your plate and screws directly overlying the pins utilized in the jigs, which makes this a procedure much less technically demanding than trying to do it by freehand. And here's a case example with the pins and then the jigs in place, and then ultimately the correction of this complex deformity as you see depicted here. Here's one last case I'll end with on the forearm. Is an 11-year-old female, Erin, who injured herself on a trampoline 3 months ago. She had very limited forearm rotation. Again, an 11-year-old female is very unlikely to remodel this deformity that's present and she has substantially limited forearm rotation. We do not think she'll remodel as she's approaching skeletal maturity, and this is less than 1 year out from the injury, which is ideally the time to interact and going to intervene to correct the deformity. So again, a volar approach utilizing to the radius and the direct approach to the ulna. And again, keeping it simple, we perform closing wedge osteotomies of both malunions. And here's the final product, as you see depicted here. And here's her forearm rotation. Not perfect with regard to supination, but pronation, in my opinion, is much more important in this day and age technology. And certainly she has functional motion at this time, much better than a 10-degree or 20-degree arc of motion. So in summary, with regard to forearm malunions, remodeling certainly has much greater limits than fractures closer to physes, particularly rapidly growing physes, such as the distal radius or proximal humerus. The malunions can lead to poor outcome, particularly loss of forearm rotation. The osteotomy will yield the best result, particularly when performed early, less than 1 year out from injury, and when there's greater than 20 degrees of angulation, and particularly in substantially deformed malunions, preoperative planning and the surgery must be executed well to obtain optimal results. So we'll continue moving distally to the distal radius. These fractures, as we all know, are extremely common, accounting for 30 to 50% of all pediatric fractures. The vast majority of these are easy to treat. They're predictable and have excellent outcomes. However, they can be difficult if they don't follow the rules. It's important to remember that 1/3 of these fractures that need to be reduced will ultimately redisplace, and therefore close observation with frequent repeat radiographs is necessary to ensure that the fracture does not go on to malunion. Here's a case of a 9-year-old who fell off a swing. And you can see the initial fractures here. And 1 week later, you can see that the fracture has gone on to begin to lose the reduction. However, that would likely be acceptable in that 9-year-old child. Here are the parameters you would find to be acceptable off of various texts. You can see them listed. Again, as you get older and approach maturity, we accept less deformity. These are the predictors of loss of reduction, including severe initial displacement, an isolated distal radius fracture, associated ulnar fracture at the same level. But the key one that we can control really deals with the initial reduction as well as the casting technique. It's very important that we have a cast index of greater than 0.7. And this is extremely important to prevent the loss of reduction. Weekly radiographs should be obtained at least every week for the first 2 weeks to ensure that the fracture is not losing alignment. And as I mentioned at the very beginning of my talk, the key is recognizing what will remodel and what will not. And the remodeling is really dependent on a number of years of growth remaining, the proximity of the rapidly growing physis, such as a distal radius, where there's 80% of longitudinal growth of the radius occurring, how much angular deformity is present, and then also the plane of angulation relative to the nearby joints. I think we all recognize that fractures closer to the physis and angulated in a plane of motion of the joint will have the greatest remodeling potential. And here's just a case example from a Yellow Journal article of a young child who was able to substantially remodel that massive deformity that was present by 18 months following the injury. So let's go to our 9-year-old male who fell off a bunk bed. We have this 100% displaced fracture of the distal radius, undergoes a closed reduction. I think we would all agree this is certainly acceptable in nature, but over time we can see that the fracture is leading into a radial deviation, but this is occurring because this cast is not well applied and not in a good position because of that increased space that's present. And that's really why that fracture fell off, because of poor cast placement. What should we do? We should do nothing. We know that this 9-year-old will remodel this deformity, and we can, again, allow for an intentional malunion to occur, because ultimately remodeling will correct the malunion without the need for surgical intervention. So can we predict how much remodeling will occur? Well, this article tried to do that. They looked at 63 children retrospectively, and they came up with a very complex formula to try and predict this. Unfortunately, this is not practical, and I have not been able to adopt this into my practice. And therefore, it really comes down to my experience and understanding of the literature to be able to predict who is going to remodel and who will not. I've developed this algorithm for distal radius fractures to treat fractures that I do not think will remodel, that have had a loss of reduction and developed either a nascent malunion or impending malunion. When I return to the operating room, the first thing I should always do is attempt my closed reduction again. If I'm able to re-reduce it, then I may be able to just place a pin to stabilize the fracture without anything needed that's more invasive. If my attempt at closed reduction is unsuccessful, then I can proceed to an osteoclasis. Again, the osteoclasis is taking the pin and placing it directly into the fracture site to break up some of that early callus formation that's present. If I'm successful at that point, I can proceed again to my place my pin to stabilize the fracture. If I'm unsuccessful with the osteoclasis and it's a physeal fracture, I can perform a very mini approach if this child is not approaching skeletal, or if this child is nearing skeletal maturity, and break up the impending union at that point in time, understanding that there likely will be a physeal arrest, and I should perform an associated distal ulnar epiphysesis. For metaphyseal fractures that are unsuccessful with regard to osteoclasis, these will require more open reduction for internal fixation. And I'm going to walk through this algorithm with various case examples. So here's a 4-year-old who fell off a swing, was placed in a long arm cast, had that initial fracture of the distal radius, and over time, 11 days post-injury, had gone on to substantial dorsal angulation that we felt was likely going to worsen over time and potentially not remodel, particularly because the ulna was not deformed with it. They went to the operating room and attempted a closed reduction unsuccessfully, as this already had early healing. And we performed a gentle osteoclasis by placement of the pin into the fracture site. And we're able to correct the deformity into acceptable alignment, not perfect, but certainly acceptable for this young child, stabilized it from worsening again, and that went on to heal without any issues whatsoever. When I perform these procedures in the operating room, I invert the fluoroscopy unit and utilize that as the operating room table, as you see depicted here. For my percutaneous pinning procedures, I do not feel as though a full prep and drape is necessary, as this just leads to increased medical waste and dollars and increases the time in the operating room. Utilize this semi-sterile technique, as you see depicted here, of just a towel on the fluoroscopy unit. We'll put gloves on only, no gowns, and we'll utilize this prep stick.
I'll take a right glove.
So you can see that our scrub person is scrubbed, but us as the surgeons will maintain the sterile field without the need for formal gowning up, just the gloves. Under sterile technique, with just our gloves and a towel, we can percutaneously place our pin and then, and then drive it across the fracture site.
Stop.
Once the pin is in an adequate position as confirmed with fluoroscopy, we can bend the pin as we would in any other manner. And here is our final product from an osteoclasis and percutaneous pinning. Again, casting is extremely important when treating these fractures, particularly the nascent malunions, as they still have potential to displace over time. And therefore, excellent casting technique is imperative. Hardware is removed at 4 weeks in the office setting, just as you would in an acute situation. Here's what the literature says about early treatment or callocasis of treating a nascent malunion. This was performed 2 to 6 weeks post-injury in this series of 21 patients. All of the patients had excellent results with less than 2 degrees of residual angulation at final follow-up, and this series did not report any complications. So let's move on down the algorithm. here's a 15-year-old male who hurt his wrist 4 weeks ago. And then it was re-injured when he was arrested by the police. And the emergency department, the residents attempted to reduce the fracture, but there was no motion present. Again, I will tell you, this child is 15 years of age, and you can see from his physes that he's almost skeletally mature. As we follow the algorithm, we go to the operating room and attempt to close reduction, which was unsuccessful. We can attempt our osteoclasis, but this is pretty well healed, as you can see. And therefore, because this child will not grow and be able to remodel this, and we are going to accept the fact that we're down to physis, we can perform a mini approach to correct this deformity that would be unacceptable in an adult population. And here we are intraoperatively. You can see this is pretty well healed at this point. We try to do the osteoclasis, understanding that we will likely damage the physis, but there's no movement present at the fracture site. What we'll do is a mini approach and place a small osteotome, 1/4 inch, through a dorsal approach directly into the fracture site, perform our osteotomy, then we can reduce the fracture and stabilize it with Steinman pins, as you see depicted here. We would normally, if the distal ulnar physis was open, perform a concomitant distal ulnar epiphysiodesis to prevent ulnar abutment syndrome, but that was not necessary. Sorry, we did do it in this case. It must have been open, sorry. Here, as you see depicted. Okay, so let's move away from physeal fractures and move to a metaphyseal fracture. Here we see a 13-year-old female who fell off a horse, had this initial distal radius end associated ulnar fractures, underwent a closed reduction. I would think we would all agree, actually the alignment is excellent, including the cast positioning. However, 2 weeks later, the child has gone on to a nascent malunion. We can see the callus formation present and a substantial deformity, particularly present in the distal radius. And again, loss of that interosseous space present distally. So if we go back to the algorithm, we'll attempt to close reduction, which will not be successful. We'll attempt osteoclasis, which was unsuccessful. And then we would proceed to a formal open reduction to fixation due to this being a metaphyseal fracture. And that's what was here, as you see, to correct the deformity. And here she is 6 weeks postoperatively, doing well. One last one, a 14-year-old child who was involved in an ATV accident. And here we see the child 3 weeks post-injury, already abundant calcification present. Likely will not remodel this completely, particularly enough to allow for good remodeling at the DRUJ, which we can see is malaligned in this radiograph. And this would undergo a formal small opening wedge osteotomy utilizing that volar approach, as you see depicted here. So I just mentioned that last case, problems with the DRUJ. There's a condition called supination dissociation, where you have malalignment of the DRUJ, which leads to a loss of supination in the child. And here you can see that deformity present curving with the dorsal angulation present that threw off the DRUJ mechanics, leading to this loss of supination. So here's a case example, a 15-year-old right-hand dominant male that was wrestling with a friend, sustained this fracture. I think we would all agree that this is very minimally displaced, not much of a big deal, but it is in 20 degrees of dorsal angulation if you measure it out. They apparently at the outside facility tried to reduce this, but in my opinion, it really didn't move, and it stayed at 20 degrees of dorsal angulation. And here it is 1 week later, no change, persistent dorsal angulation. And here it is a month, and here it is 3 months, allowed to unite in that dorsal angulated posture. A little bit of remodeling has certainly occurred, as we all see here. What happened, though, is as this child grew, this deformity migrates proximally, and that's really what throws off the forearm biomechanics. And ultimately, the child presented to me 1 year post-injury with complaints of limited forearm rotation, of only 30 degrees of supination compared to 80 degrees on the right side. And these were the current radiographs. And again, this is not as dramatic as the first picture I showed you, but you can start to see that deformity that's present and migrated proximally into the forearm that's led to decrease of forearm rotation. And here it only measured out to about 10 degrees. So the child was able to remodel 10 degrees of the initial deformity, but the slight dorsal curvature in the distal third of the forearm has led to that decreased supination. And this is treated with a radial osteotomy to correct that dorsal tilt. And immediately post-operatively, we were able to achieve at least 50 degrees of supination into functional motion for the child. I'll end distal radius with a crazy case. This is a Malunion and physeal arrest of the child that presented 7 years after the original injury with complaints of deformity and pain due to ulnar abutment syndrome. As you see here, here are the child's initial radiographs from the injury. Here's the post-reduction and casting. It's not perfect, but likely acceptable at the time, given the child's age. But 7 years later, the patient came to my office with this gross deformity and a substantial ulnar positivity. And this is the radiographs. Here you see obvious ulnar positivity, but really reversal of the radial inclination. And this occurred due to a physeal arrest that was partial in nature with continued growth of the ulna. And here the child is going to be brought to the operating room for an osteotomy to try and improve the positioning. And this was treated with an iliac crest bone graft, as you see obtained here, a laminar spreader placed in the osteotomy site. And certainly we did not get a perfect result, but something much better to prevent his deformity. We accepted the fact that the plate was a little bit off the bone and planned removal, and the child needed concomitant ulnar shortening osteotomy and distal ulnar epiphyseodesis. So in conclusion, for distal radius fractures, one should not accept an unacceptable reduction. You want to treat this early with ideally anatomic reduction or certainly acceptable alignment. You want to avoid multiple or late reduction attempts, as this can lead to physeal arrest. You want to make sure you have excellent casting technique to limit the chance of loss of alignment. And you want to make sure that you follow these weekly for at least 2, if not 3 weeks, to ensure maintenance of acceptable alignment. Remember that a fracture in a preteen can become a form deformity as the child grows and the fracture deformity migrates proximally. You must inform parents about potential for loss reduction and physeal arrest. And it's always important to bring these patients back for repeat radiographs to assess for physeal arrest following these injuries. So I'll end on hand fractures, and then we can go to Q&A. So the first topic I wanted to bring up was first metacarpal base fractures. These can be quite tricky fractures to diagnose, certainly to treat at times due to ligamentous pull at the base of the first metacarpal. Here's a case example of a 17-year-old football player that hurt his thumb and had pain in the CMC region. And these radiographs do not demonstrate anything substantial. And I would argue that these are not adequate radiographs because there's no true lateral nor a true PA view for us to have orthogonal views to look at that CMC joint region. This tuberosity initially was thought by someone to be a fracture. The child was casted for 3 to 4 weeks. The cast was removed and the child was doing okay and returned to that person 4 weeks later, now 8 weeks out from their injury, still with pain. And now we can see that small fracture fragment that was present all along that was not treated right at the base of the first metacarpal. So the initial provider had recommended therapy despite this malunion. And you can see that this is actually the fracture fragment, as we all know from our adult hand surgeon colleagues, that this is fracture fragment stays in the anatomic position, actually the metacarpal, the shaft that migrates out of position. And here we can see abutment. And it's no surprise that despite therapy, the child still had pain and was ultimately referred to me. And here are his intraoperative fluoroscopy images. I think you all know that this was treated with an osteotomy to correct that malunion and restore anatomic alignment of the CMC joint of the first ray. Here's another example, a 13-year-old male who hurt his thumb playing baseball 4 weeks ago. Someone had run into him. Initially, I'm not sure, I don't recall the specifics, if this fracture was missed because of the overriding nature from the institution, or a child initially did not present to someone, but I'm pretty sure he did present and this was missed and not recognized as a fracture early on. And my questions would be, what diagnosis, I just gave you that obviously, but need any additional imaging, what would your treatment plan be? And here it is zoomed in with adequate radiographs, really at a PA view of that first ray. And it's pretty clear that this child had a first metacarpal fracture that's 100% displaced and overriding. And this was taken to the operating room to correct the malunion and get the first ray out to length, and then fixed with the K-wires, as you hear. Finger fractures, condylar fractures, I think we all recognize that we would need to get our condyles out to length and restore the articular surfaces as much as possible. This is a 13-year-old female who injured her small finger 6 weeks ago. She had some pain, but really didn't present until her deformity occurred. And here you can already see a nascent malunion occurring with some early calcification present on the finger. And this was treated in the operating room with a small osteotomy of that region. It's important that you avoid damaging the collateral ligament, as this is where the blood supply comes to the condyles. So a minimally invasive approach is ideal. And you can fix these in various ways: plate and screw fixation, or here you see a little combination of a screw and a K-wire, but lots of options to stabilize this once you get it back out to length. And then phalangeal neck fractures. Hopefully everyone's familiar with these injuries. There are lots of different names for the same fracture. These are transverse fractures in the neck of the phalanx, usually the proximal or middle phalanx. These are seen primarily in children and most commonly occur due to crush mechanisms, particularly in young children when their finger is caught in a door. A child tries to pull their finger out and they get a fracture to subchondral region. These are important to recognize as they often can get missed. You get volar angulation at the fracture site with dorsal displacement of the condyles and extension of the condylar fracture fragment. And these get missed because on the PA view, can look minimally displaced or just non-displaced really. And it's not until you have the true lateral view that you can see the displacement present. And these fracture fragments can be quite small due to the cartilaginous nature of the articular surface. You need near anatomic reduction to restore the subcondylar recess to allow for that hyperflexion, particularly of your IP joint, which goes beyond 90 degrees when flexing. I think this is analogous to a supracondylar fracture with the anterior humeral line, and we published an article discussing a volar phalangeal line. Basically, it's the same concept. You want to draw a line and make sure that your condyles are sitting volar to this line to ensure that you can obtain that adequate flexion into the subcondylar recess, as you see depicted here. If you don't, certainly the child can lose the flexion. They may also have malrotation present and lead to deformity and scissoring of the fingers, and all of this you want to avoid. So again, if it's a nascent malunion, this common theme that you've heard throughout this talk, an osteoclasis is an excellent technique. You can perform this and then do a dorsal block pinning and place your pins to treat the fracture. If you're going to perform an open reduction, again, you need to protect the blood supply, which is entering through your collateral ligaments. Here's a schematic of the osteoclasis technique. You can see the fracture with the healing callus, the K-wire introduced into the fracture site, breaking up that callus, and then you can utilize the K-wire similar to a Kapanji type technique in the adult distal radius population to lever the distal fracture fragment into place and then stabilize it with an additional wire or two. Here's a case example of a 10-year-old female. You can see the fracture fragment sitting dorsally, the osteoclasis performed, and levering the distal fragment into a position and stabilizing it with an additional K-wire. Once an established malunion has occurred, you can see if you think the fracture will remodel. This is slow as the fracture is far away from the physis, since the physis is proximal in the phalanges and these fractures are distal in nature. There was a small series out of our friends in Atlanta that followed 8 patients for at least a year. And what they found was there was a fair amount of sagittal plane remodeling from 31 degrees to 0, but the coronal plane did not remodel very well, with the patient still having residual deformity present in the coronal plane, leading to 25%, 2 other 8 patients still having complaints of cosmetic coronal plane deformity present. An alternative option besides an osteotomy is a subchondral fossa reconstruction. This can be performed with a volar approach where you basically carve out that subchondral recess with a small burr. This can improve motion, but certainly does not normalize it. And then when necessary, you can perform an formal osteotomy as you see depicted here for this fracture fragment, to correct both the coronal plane deformity as well as improve sagittal plane deformity. So in conclusion, malunions of the pediatric upper extremity are extremely common. It's important that we, as pediatric orthopedic surgeons, understand what will remodel and what won't. And if the fracture is not going to remodel, we want to try and act early with less invasive techniques, such as an osteoclasis. And if a formal osteotomy is needed, my preference in the vast majority of situations is to perform a closing wedge osteotomy whenever possible. Thank you for your attention. I hope everyone enjoyed that.
Well, thank you, Dr. Abzug, for a very, very practical and a really exhaustive overview of the entire gamut of malunions, I think, right from the humerus, proximal humerus, right to the tip of the fingers. And I must congratulate you. It was very well covered and very case-based, so I'm sure our audience has enjoyed it. So we have some questions pouring in for you. The first of them is from Rajiv himself, and he says he would like to know your opinion on treatment of plastic deformation.
Yes. So again, I think plastic deformation depends on one, the age of the child, but really more importantly, what's happening with it. So if it's plastic deformation of the radius and ulna, then that might be okay, particularly in a young child without any necessary intervention. However, we need to be very careful, particularly with plastic deformation in the form, if there's plastic deformation of the ulna that can lead to a Montasia fracture dislocation. So a small amount of plastic deformation in the ulna only can lead to ultimately the radial head dislocating from a Montasia fracture dislocation deformity, and that will require treatment with an ostomy down the road of the ulna. So I think, again, you need to recognize what will remodel and what won't remodel, and understand if the deformation is in both bones of the form or just the one bone.
So the other question again is followed by Rajiv with regards to the Montagia, that if you could spell out the when to intervene and when not to intervene, what would be your criteria in the Montagia, conservative versus operative, so
Sure.
that you don't end up with a late radial head dislocation?
Yes. So I thought about putting that into this talk, but that's, as everyone knows, can be a full 45 minutes in itself. So I purposely stayed away from it. But I think the key with Montasias is to be aggressive early to prevent the late radial head dislocations. So when in doubt, I will treat the ulnar fracture or an acute Montasia fracture with fixation early on to ensure and prevent late dislocation of the radial head. So for example, in a transverse fracture of the ulna, if I have any question whatsoever, I will put a flexible nail or a big Simon pin down the canal of the ulna, treat it in any length stable fracture early on, if I feel as though there's any change in alignment following the initial closed reduction. If it's an unstable fracture, then I will certainly go early on to plate and screw fixation. And there was a study by CHOP that showed this algorithm for intramedullary fixation, for length stable fractures, opening reduction, and plate and screw fixation for length unstable fractures led to excellent outcomes. Because as all of us know that treat late presenting Montasia fracture dislocations, they can be very challenging, and us being a little bit more aggressive early on can lead to preventing those problems later on. In the very young child, the last comment I'll make is when in doubt, I will perform an arthrogram in the operating room to assess the radial head, because I think we sometimes get fooled, particularly in a young child, I'll say under 4 or 5 years of age, thinking that the radial head is lined up, pointing okay. But if we do that arthrogram, we can see that there's really subluxation of that radial head, and we need to correct and intervene the ulnar deformity to align that radiocapitellar joint into anatomic position. So hopefully that's a short answer that covers Rajiv's question without getting into too much time on that topic.
Yeah, that's quite nice. There's one more question from Dr. Jaswinder in Patna. what would be an indication to use bone graft after osteotomy for malunion correction?
Yes. So in my hands, as I hope you gleaned from the talk, I think one of the keys to malunion correction is trying to keep it simple. I think we as surgeons want to do more complex surgery because we find it fun, but I think we all recognize that leads to more complications and less optimal outcomes. And I think that's very true as we talk about malunion correction, where I understand on paper how to perform a dome osteotomy in a supracondylar region, and I've done it, but it's much more technically demanding, and I think the outcomes are not as good as performing simple closing wedge osteotomies, either uniplanar or biplanar, if we can correct enough deformity. So utilizing a closing wedge osteotomy obviates the need for the bone graft because we get good bone-to-bone contact and these typically young, healthy children without the need to place a bone graft. It's when you get into opening wedge osteotomies that you need to place the bone graft. And that's where, again, I think in my hands and most people's hands in the literature, that more complications occur. So I think the key is really to try and keep it as simple as possible to correct the osteotomy, to correct the malunion, and that's typically performed with a closing wedge osteotomy.
Yes. And 2 questions from Sandeep. Is it mandatory to correct all components of a cubitus varus? And what is the optimal age when you would recommend a correction? So we could take it one at a time if you wish. Is it mandatory to correct all components of cubitus varus?
Right. So I think, and I didn't get into this a lot in my talk, but when I talk mainly on malunions just on the elbow, or really any malunion, I think it's, again, important for us to take a step back and remember that our job as a surgeon is not always to just correct something because we see something that's deformed. And this really comes from my training with regard to congenital hand deformities, where we may, or a toe syndactyly is a great example. Just because a toe syndactyly exists doesn't mean we need to separate those toes because there's no functional limitation present. So I think as we talk about cubitus varus in particular, for me, every time I discuss cubitus varus, I have a very long conversation with the parent because I need to understand what the goal of the surgery is and why we're doing it. And is it just a cosmetic surgery, or are we doing it to prevent the potential for the posterior lateral rotatory instability that we discussed earlier, or the repeat fractures, or does this patient already have a snapping triceps tendon and that's why they're here, and the cubitus varus is the underlying reason for the snapping triceps tendon? So I think that, and the same is true as we were to go to the forearm and discuss, a forearm osteotomy, what our goal of that operation is. So I think cubitus varus is harder because we recognize that even though I listed all of those potentials, the repeat fracture, the snapping tendon, the instability, those are pretty rare. And there are a lot of people walking around with cubitus varus that have no functional limitations whatsoever. And it's purely a cosmetic deformity. And if it's purely a cosmetic deformity, the parents need to recognize that there's going to be a pretty big scar, as you saw in my video and my pictures, present to perform the osteotomy. And they're going to be taking something that doesn't have a scar on the arm and have an operation that corrects this deformity, which may be less obvious than the scar itself. So I think that becomes a very deep conversation with the parents. But if you are going to correct the deformity, I think you want to correct it to match the other side, is the short answer to the question, as much as possible in both planes, right? So if it is extended, I will build in some flexion into my osteotomy. And if it's true, just sagittal plane or coronal plane deformity with the cubitus varus, then I'll try and match the amount of valgus on the contralateral limb to correct it as much as possible. And typically by placing those 2 K wires, one parallel to the joint and one perpendicular to the shaft, that basically will do it for you because that's where the child was meant to be.
And his second question was, what is his optimal, what's your optimal age at which you would recommend the correction?
Yeah, so this goes back into part A of my answer to the last one, into the conversation. Particularly in young children, parents aren't sure that it's really bothering the child and are happy to watch it typically remodel. I would say ideally from my hands, a couple of things. One, if I'm going to correct it, I think earlier is better because particularly in a growing child, that cora, right, center angle is going to migrate. And you want to try and keep it as distal as possible into the metaphysis to better healing. So that's number one. So I'll give you a number of within 2 to 3 years following the injury if you're watching it for a period of time. But the second comment I'll make is I think earlier is better with regard to age. So ideally utilizing fixation that's K-wires instead of having to go to a plate and screw fixation as a child is older. I think parents are happier to have the wires removed and not necessarily leave a plate and screws inside the child. And sometimes if you go into plate and screw fixation or as a child is older or a young adult, as you saw in the video or my pictures, we'll go medially to release the ulnar nerve and transpose it. So now you have 2 incisions and a much more involved operation. So I think the bottom line is sooner rather than later and younger rather than older.
Okay, we have another question coming in from Anirban. In distal radius physeal fractures, one of the dictums was not to be aggressive in correction after the initial 7 to 10 days, since the risk of iatrogenic physeal injury is high. Does the MIS algorithm give less physeal arrest in the long run?
Does the which algorithm? My algorithm?
Yes, the MIS,
Yeah.
the minimally invasive algorithm.
Yeah, so my algorithm really deals with non-union or malunions that we know are going to occur that will not remodel. As you saw with my mini osteotomy, as I followed that algorithm down, the only reason I performed that mini osteotomy was because it was a male that was 15 years of age and had minimal growth remaining. If that was a 8-year-old, for example, we would never perform an osteotomy or do any attempt at osteoclasis near the physis beyond about 10 to 14 days from the injury due to increasing the chance of physeal arrest. We would allow that to remodel, and if it didn't remodel down the road, then we would perform a formal osteotomy later on once the child was done growing. But typically, as long as there's 2 years of growth remaining, most of them will remodel if they're physeal fractures.
So, and yet I think cubitus varus seems to be a really popular topic. So we have another question coming in saying, have you experienced any recurrence during the cubitus varus corrections due to AVN of trochlea? And if so, how do you deal with it?
Yeah, so yes, I've seen recurrence occur. So I think we need to break it into 2 parts. So recurrence has occurred due to incomplete correction. So it wasn't necessarily true recurrence, but someone who performed the osteotomy initially and didn't get adequate correction of the varus. And then as the child grows, it becomes more obvious again later on, particularly as that deformity migrates proximally. And then number 2, we've seen recurrence due to physeal arrest of the distal humerus, and that can certainly lead to recurrence of cubitus varus deformity after correction. So again, you got to be very careful with your technique. Make sure that you do avoid posterior dissection as you're in that metaphysis, because you don't want to damage any of the blood supply to the distal humerus.
Okay, thank you. And a question from me now. Any particular reason for doing the humerus, proximal humerus unions in the chair position as supine? Does that kind of help you do the maneuver of reduction? And if so, any tips about the same?
Sorry, you broke up a little bit. I'm not sure if someone else heard that. Repeat, or if you want to try again.
So when you do it, the proximal humerus in the beach chair position, why do you prefer it versus doing it in supine? And any tips for the maneuver of reduction?
Yes, got it. Okay, so I prefer beach chair position because typically the proximal spike of the distal fragment has migrated proximally, right? And we need to get it down underneath the head and neck region. So I think by putting them into beach chair, gravity is going to help me pull that distal fragment, the shaft of the humerus, underneath the head and neck. And then my trick is a cob or a bone hook right into the medullary canal of that distal fragment. So I'll put the bone hook in and pull the shaft down underneath the head and neck. Or I'll put the cob in and try and use the cob to and slide the shaft under the cob to get it under the head and neck. And I think that by the beach chair I'm having gravity help me, and I can flex the elbow and pull on the shaft of the arm. Whereas if I was supine, I'm basically just trying to pull longitudinal traction without the assistance of gravity.
Dr. Bala from Calcutta wants to ask you, what is the chance of a compartment syndrome after closed osteoplasis in maluniting both bones forearm, and how do we prevent it?
Yeah, so if I'm doing a formal osteotomy of both the radius and ulna, or even one, I will extend my fasciotomies under the skin, proximally and distally, well beyond my osteotomy cut. Typically, as we all recognize, the osteotomy is performed in the mid or proximal third of the forearm, and therefore you can get a pretty good fasciotomy performed at the time of your osteotomy, certainly by extending your scissors proximally and distally to release the fascia by underneath the skin. So that's a big way of preventing it. Number two, all my osteotomy patients are splinted, not placed in a cast with a sugar tongue splint. And then number three, they're admitted to the hospital overnight for at least one night, especially when I'm doing both the radius and ulna in a rotational manner, or something such as if I ever needed to do an opening wedge manner, such as that child I showed, as opposed to closing wedge osteotomies, which I'm less concerned about compartment syndrome because we're shortening the bone. And I think we just need to recognize that the compartment syndrome in children is different than the adults, and we're really looking for that increasing analgesia requirements. So if they're admitted, they get very low dose or no narcotics, and we track what they're taking for their pain medication overnight and ensure that they're not requesting more and more and more, in which case we'd be worried about compartment syndrome. But I think the key intraoperative move is extending your fasciotomies beneath the skin.
Okay, we will take just last two questions before we go on to the cases. One is from Dr. Somesh Virmani, Delhi. How do you manage fracture radial neck with an angulation malunion more than 60 degrees and presenting about 12, 14 days later? And also an established radial neck malunion. So what he means is a late presenting radial neck and then an established malunion of the radial neck.
Yes. So the early on one, so we'll stick to my terminology, nascent malunion, the one that occurs that you see at 12 to 14 days. I will try and reduce anatomically back. Again, I'll utilize an osteoclasis type procedure. If anyone's familiar with the Bowler procedure, where I'll take a Steinman pin, introduce it percutaneously through the skin on the sharp end, remove it, and then turn around and use the blunt end to try and break up some of that callus and use it as a tamp with a mallet to try and tilt the radial neck back into alignment. If that's not successful, I am a little bit more aggressive in open reduction of a radial neck fracture, even in a younger child, because growth arrest of the proximal radius is one, pretty rare, and two, if it does occur, lots of times we don't necessarily need to do treatment for it. So we want to get it back because, as I answer part two of that question, treatment of a established radial neck malunion is extremely difficult. I've done osteotomies of the proximal radius, and the problem is that the deformity, by the time you have an established malunion of the proximal radius, typically it's a year or two out from the injury, and you have deformation of the radiocapitellar joint. And when you perform osteotomy and place the radial head back aligned with the capitellum with forearm rotation, it tends to spin out. So it'll be aligned in either pronation or supination. And when you turn the forearm, it actually spins out of off of the capitellum because of the deformity and wearing of the articular cartilage that has occurred. And therefore, you want to treat these, again, very early on. So as soon as I see a malunion of the proximal radius, I will fix that as early as possible.
In continuation of Dr. Bala's question, he wanted to know if you have encountered compartment syndrome in a closed both bones forearm malunion while doing an osteoclasis and not while doing an open reduction.
I personally have not. Again, I think we need to be smart in what we do. the osteoclasis is done 12 to 14 days. And honestly, osteoclasis, it allows for less force to be applied because the fracture already has some callus there, as we know. And by breaking it up, it's almost like just pushing the glue into something that has glue on it and falling off, and you're just kind of gently pushing it back into position. So it's much less force than trying to get something out to length, which is where more commonly you'll see compartment syndrome occur, or multiple reduction attempts. Now, I would say the other comment on osteoclasis is it either works or doesn't. So you'll perform your osteoclasis and again, gently manipulate things back into place. And if it doesn't work after a couple of minutes, then we're always prepared to proceed to a formal open reduction or correction of the malunion. So it's not where you're going to be pulling for 20 minutes or 30 minutes, where people may try that in the acute setting, more likely to have compartment syndrome.
Okay, so while I ask Rajiv to get the cases ready, which we are going to present in 3 modules. Module 1 will be presented by Rajiv. I'm sorry, Anirban. Module 2 will be presented by Rajiv, and module 3, if there's time permitting, then I will step in. We just have time for one last question from the internet again, where someone has asked you, when you do the, you use jigs for correcting your malunions, would you prefer them a percutaneous osteotomy, or do you prefer to have it done mini-open?
Yeah, so the jigs I showed are for very complex deformities where you've gotten a CAT scan and the company will manufacture those jigs for that specific patient. They're patient specific, in which case those are designed to be performed full open. And again, those are the ones that you'll worry about compartment syndrome because you're typically correcting a massive deformity, and it's typically in both bones of the forearm, and you'll perform your fasciotomies. So it's a full open procedure.
All right, thank you so much. So we have about over 600 people tuned in and more expected to join in even for the re-reviews. So that's quite a good number for a weekday. And Rajiv, can I request you to share your screen and begin the first module, and everyone else to switch off their microphones while he presents that?
I think Dr. Anirban has to present this case.
Rajiv, I think the first case is yours. You can present that.
Okay.
Go ahead, Rajiv. Go ahead, Rajiv.
Yeah. Just 1 second. Yeah, so this is a 10-year-old child who had a supracondyle fracture at 6 years of age. He was treated with close reduction and cast at that time. Subsequently, he developed cubitus varus, and he was operated with a modified French osteotomy after 2 years for his cubitus varus correction. And when he presented to me, he had persistent varus of 20 degrees with range of motion of 20 to 130 degrees. So this is his clinical picture and video. And this is his X-ray which he had come up with. So I would like to know from Dr. Abzug how he would like to approach this case.
Sure. So I think we'll back up a little bit and just stay on this picture, please. I think we recognize the French osteotomy is very similar to the technique that I described. Instead of fixing the osteotomy with K-wires or Simon pins or plate and screws, this wire is woven around these 2 screws. The concern with that is that the wire can obviously break. We certainly see an end of the wire here. I don't know if that's the end that was twisted or if that's where the wire broke. If it's where the wire broke, then the recurrence of the deformity certainly occurred because all that was done was an osteotomy, and then the 2 screws were placed, and nothing held the osteotomy to allow it to heal and not drift back into varus. If the wire did not break, then certainly we'd have to question how much correction was performed by the original surgeon. So certainly when I have a case like this, I always try to go back and have the patient get all the x-rays that led to this point so I can see the original injury as well as the x-ray before the surgery, initial surgery was performed, and then obviously the latest x-rays. So I think always find it helpful to go back if possible and get those x-rays. In this case, as we say, what are we going to do? I would like to see a little bit more of the distal humerus and a better x-ray. And if not possible, then I may consider getting a CAT scan or an MRI of the distal humerus just to assess the physis, particularly here on the lateral side. I want to make sure that that physis is open. If it's not, we're going to have continued deformity occur. Typically, however, would then lead to cubitus valgus down the road, but certainly that would be important information to know what's happening with the physis right here. The bottom line is, if we're going to proceed with correcting this deformity at this point, I think that one other comment is this osteotomy is a little high. Now, possibly the child grew, but if you went through my technique, I like to be above the olecranon fossa, so lower down for this osteotomy. And I would do my closing wedge osteotomy with a K-wire going from here and probably one roughly there to take that wedge out, as I showed in the video and my talk. And then I don't like that the child only has 130 degrees of flexion. I probably would build a little extra flexion in, understanding that the child will have worsening ability to straighten the elbow, but elbow extension, I think we all recognize, is less important than elbow flexion. I want to make sure this child can get their hand to their face for hygiene purposes and potentially their hand to their ear for a cell phone purposes in this day and age.
Thank you. So we are due to operate this child and he could not come in because of this COVID situation. So hopefully we'll take your advice and operate him subsequently.
So let's go on to Anirban.
Yeah, okay. Rajiv, can you continue with the, yeah. So, yeah, next slide, please. Yeah. So my case was a 21-year-old male who had a right cubitus valgus deformity, and he had a history of childhood injury to the right elbow, which was initially treated conservatively. Now, when he presented to us with this amount of deformity, you can see the pre-op range of motion is almost up to 130 degree of flexion, and he has a bit of hyperextension as well. So the X-rays, you can see on the affected side, it's about a 20-25 degree cubitus varus as compared to the contralateral normal side. Now, the arrow is being shown. Hopefully, there's no issue in the epiphysis there. You can see the joint line is quite well maintained. Now, whenever we plan an osteotomy in a skeletally more mature patient, there are certain queries which come to our mind. I would put these queries to Dr. Joshua. Well, would we do the same sort of osteotomy as we do in children? Should it be the same lateral closed wedge osteotomy or a medial closed wedge, or do a more geometric or a dome type? And what should be the method of fixation? I mean, should it be the same as we would do in children, just K-wires, or should we go for more rigid fixation methods?
Great, thank you for those questions. So as far as, I'm going to go backwards, the method of fixation, as I alluded to, as the child approaches skeletal maturity in an older child, and certainly in the adult population, we want to stabilize the osteotomy with plate and screw fixation. This is for a few reasons. One, it will allow for earlier range of motion. While we say children's elbows don't get stiff, one, they do get stiff, but certainly in adult population, we want to allow for early range of motion of the elbow, and the plate and screw fixation will allow that. Typically, you do not need to do bicolumnar plate fixation in adult if you're performing a simple closing wedge osteotomy. If you're going to perform a dome or some sort of geometric osteotomy, depending on how invasive it is, quite often I'll add dual plates, either 90-90 or parallel plates to fix and again allow for some early motion at the elbow. As far as what type of osteotomy, in my opinion, it doesn't really matter whether it's a child or adult. What matters for the type of osteotomy is the deformity present. So again, in my hands, I do really try hard to keep it as simple as possible. So in this particular case, where it was really just a coronal plane deformity, the young adult had excellent elbow flexion that certainly was in functional motion, as well as his elbow extension. I would perform a simple lateral closing wedge osteotomy. However, I would add in that medial sided incision to transpose the ulnar nerve and take off a little bit of the prominence that will occur from the lateral closing wedge osteotomy. There's nothing wrong with doing a dome or a geometric osteotomy. I just think that they're more complicated and technically demanding, and therefore the outcomes and overall complication rates have been shown to be higher in those circumstances.
Okay.
So Ban, you should go ahead and show us what you did.
Yeah. Next, so these were the queries which we yeah, so these were the queries which we had. One more question we had was what should be the approach, and should we do a olecranon osteotomy to get better exposure? So
yeah, so sorry, go ahead.
Yeah, your take on that, whether we need a more extensive approach like the olecranon osteotomy or just a simple lateral approach like you had shown for your cases would be sufficient?
Yeah, so I would do the simple lateral approach, and then again, in this case, for the adult, I would add in the medial approach to transpose the ulnar nerve. And I think that an olecranon osteotomy is not necessary for these procedures because these are extra articular procedures, and therefore you do not need access to the elbow joint itself. These are extra articular osteotomies, and in my opinion, there's no need to go violating the elbow joint and particularly adding in olecranon osteotomy.
Right. So next slide, Rajiv, please, if you would advance.
Yeah.
Yeah, so we did a literature survey. Next, there weren't a lot of series on adult ones. This technique of an oblique closing wedge with, like you mentioned, a single lateral plate fixation was there, described from Korea. So we went ahead and did that. Next slide. Yeah, so the advantages of this osteotomy, the oblique plane, as mentioned by the authors, is that you had a higher contact area and lesser chances of lateral condylar prominence. And since the plate is applied on the lateral tension surface, so only a single plate gives you adequate stable fixation, and you can mobilize them fairly early to reduce the risk of elbow stiffness. So we went ahead and did that. And you can see the post-op X-ray. So that's how it looked immediately post-operatively. And you can see that we've corrected the varus angle as well, and you've just used a lateral plate for fixation. And at follow-up, yeah, this is the final follow-up I have at 1 year. You can see the deformity is fully corrected. The osteotomy has healed quite well. And he's got back his full range of motion and with a good cosmetic and functional result. So the take-home points that I could mention for this case is that the oblique osteotomy is, like you mentioned, relatively easier, allowed the translation of the fragment. A single lateral plate did provide stable fixation and early mobilization was possible.
Excellent job.
Thank you. Thank you.
So we move on to the next segment because there are quite a few cases in that. 3 cases. I think, Rajiv, you should run through all 3 and then we'll have Dr. Joshua commenting on each.
Okay. Yeah, so this is a 6-year-old child who had a green stick fracture of radius and displaced fracture of ulna and underwent close reduction and cast. And this was his post-union with a radius angulation and rotation.
Rajiv, can I interrupt you? I'm so sorry. I
Sure.
know we're trying to go quickly, but I just think it's important to, can you go back one slide?
Yep.
I think it's important for everyone to recognize that we do not have adequate x-rays to truly assess what is happening. And whoever was treating this early on did not have adequate x-rays. On the left side, we see an AP is labeled, and it's really an AP of the elbow proximally and a lateral at the wrist. And on the lateral side on the right, we don't have a true lateral at the wrist. And again, we have an AP sort of view at the elbow. And that's really unacceptable for everyone out there. You really need orthogonal views at every time point to really be able to accurately assess what is going on. Sorry to interrupt. I just thought it's a very important.
No, that's a very valid point. So I think that's the one of the reasons for putting this up is that when you're dealing with malunions, you must take the correct X-ray. Go on, Rajiv.
Yeah. So this child had a 40 degrees restriction of supination even after waiting for 2 years. So now my questions are, will it remodel and how long do I wait further?
Okay, and I'm criticizing you. I think that the reason that went on to that malunion was whoever was treating it early on had probably poor x-rays like that, and it looked okay, so to speak, but the x-rays were not adequate. So will this model? The answer is no. And again, right back to my same point, we almost have an AP view proximally on the picture on the left and a true lateral view on the picture on the right, of the wrist on the picture on the left. So this is obviously a rotational deformity present, and we know that all rotation deformities will not remodel. Now we can accept some malrotation in a malunion, as I mentioned, typically up to 20 or 30 degrees, but we know that that will never remodel. It's just accepted by the patient and not functionally limiting. And at this point, since we know this will not remodel, off of my talk, sooner is better. So I would recommend intervening sooner. And honestly, if this showed up in my office now in this scenario, I would recommend proceeding with osteotomies of both the radius and ulna now.
Okay. So quickly go ahead, Rajiv. We have only 2.5 minutes left now, as I'm told.
Yeah, so we have so we underwent only radius corrective osteotomy and we did not touch the ulna, and he had a good function after the union.
So quick comments, Dr. Joshua, on using only a single bone fixation when dealing with something like this.
Yeah, so I think it's okay if you can correct enough of the deformity. I'd have to go back and look at the previous x-rays and the ulnar deformity, but certainly here it's lined up fine. Yeah, so, and it worked well.
Okay, go on with the next one, come on.
Yeah, so this is this is a 3.5-year-old child who was treated conservatively, and this was his initial x-ray when he was presented to a doctor, and this was the x-ray when he took out the plaster, and the primary surgeon felt that this is going into a malunion, so he decided to underwent deformity correction. So quick comment from you, Dr. Abzug.
No, Rajiv, go on. Okay. We just finished the whole case.
Yeah, so so this child underwent a corrective osteotomy and fixation with K wires, and the K wires were removed in 4 weeks time, and this looks like going into a non-union malunion situation where the bones are not uniting, as well as there is a deformity. Yeah. So yeah, ultimately he went into a hypertrophic kind of a non-union with deformity, and there were cafeolic like spots which were there, but eventually he turned out to be a non-neurofibroma case. So we did a corrective osteotomy and treated him with plates, and he united very well.
So Dr. Joshua's comments on the age of the child and the path which was followed, and what would you have done instead? And if faced with a malunion or a non-union, your thoughts on what could be the possible reasons in a young child for non-unions?
Sure. So I think we had to recognize again that this was a 3.5-year-old child with lots of remodeling potential, and that those initial x-rays were, again, sorry to repeat, but inadequate, particularly the lateral view. The coronal plane alignment was adequate and certainly acceptable. And this goes way back to my second slide in my talk, that our job is to understand what will remodel and what will not remodel. And if the bone will remodel, we should not intervene. The next comment I'll make is after the initial osteotomies were performed and intramedullary fixation was utilized, 4 weeks time is not enough, particularly in a forearm. Intramedullary fixation in my hands is in for a minimum of 12 weeks, if not even closer to 16 weeks. If I do remove it earlier, then the child remains in plaster or fiberglass casting until I am definitive that union has occurred. As far as what causes non-unions, that list is exhaustive, but certainly in this case, it was due to inadequate fixation of the bone and early removal of the intramedullary fixation. We always worry about neurofibromatosis as a potential cause of non-union, but again, it can be hypertrophic in nature. That was not the case here, but I think the hypertrophic nature of this non-union was really due to early removal of the fixation and inadequate mobilization.
Right. So I think we are almost running out of time, and I would request Sandeep to really give his last closing remarks. Though personally, I think it's been a really exhaustive, very, very practical, and pretty technique-related talk. And thank you so much for that.
That was a very nice talk, Joshua, and you really clarified a lot of concepts very succinctly. I think the most important takeaway for us has been that the way you classified the nascent non-unions or the nascent malunions, I would say, because that is the time where you can get the anatomic alignment to restore function as well as cosmesis by a minimally invasive technique. I'm sure that it does have a small learning curve, but most of us will get over that and will be able to manage the patients much better rather than accepting a malunion which may cause problems later on. I think that should be the take-home message from malunions. Secondly, I thought the osteotomies around the growth plates have to be reserved towards adolescence when not much growth is remaining. So it's not as if you are saying that you're going to do that at lower end radius when the child is 6 years or 7 years old. I'm sure that wasn't the message, because that would definitely cause a growth arrest. So all in all, it was very enlightening, and I do hope you come to Goa. Thank you very much for your time, and we will email you with more questions. Thank you, panel, Rajiv, Anirban, and Rujuta. Thank you very much.
Thank you, Dhiren Bhai and Sandeep, for this opportunity. And thank you once again, Dr. Joshua, and stay safe. And we wish everybody comes out of this pandemic happy and kicking. Bye-bye.
Thank you. Bye-bye.
Good night.
Good night.
Good night.
Thank you all.